health insurance. You will note that we are going to record this webinar and we hope to put it up on the web afterwards so that those who couldn't join us this morning would be able to access it. I would like to welcome our speakers and our facilitator, Andy Gray, who will facilitate this afternoon's discussion. And I just want to give a little bit of background to this webinar series. The Health Justice Initiative drafted an issue paper on a number of key questions that arose for us out of the old NHI bill. And this became a focus point of having a number of broader discussions with civil society and researchers on some of the technical aspects, especially around medicines pricing selection and procurement. We've had 2 webinars thus far. The one was on pricing. The second webinar in June was on the issue of the National Assembly and the bill that was passed, an analysis of that. And this morning we'll be speaking very much focusedly on transparency, accountability, and monitoring and evaluation. Soon I will share some of the links to the issue paper and some of the other webinars if you're interested in accessing those. And I would like to hand over to Andy and our speakers to take it away. Thank you, Andy.
Thanks very much, Marlies, and welcome everyone. As Marlies has indicated, this is the 3rd in the series, and the focus today is on transparency and accountability, monitoring and evaluation. So if we had to look at the specific questions that have been asked, they would include what metrics would be set, by whom would they be measured, and how would they be reported on NHI delivery. We want to know, would this go beyond the annual report submitted to Parliament by the board of the NHI fund? And what databases are or will be publicly available and accessible from which to extract such metrics? And are these publicly accessible in terms of quality of care? So would someone be able to, for example, see what the quality of care is like at a facility or by a multidisciplinary team? Are those measures going to be meaningful for the public? We also would like to know what we've learned so far from the Office of Health Standards Compliance, and as well the attempts by medical schemes to rate private hospitals. We are focused a lot on the issue of medicines, so what specific measures are envisaged to enable and promote public transparency related to medicine selection, procurement, pricing, and contracting. And then lastly, we'd like to raise the issue of the ministerial advisory committees and the extent to which their deliberations will be open to the public, and how often the information that they deliberate on would be shared with the public. So we are very privileged today to have 2 key inputs. The first will be from Professor Ronel Burger from Stellenbosch University. And Ronel has written extensively on the issues of accountability as well as monitoring and evaluation. So she'll start off with the more theoretical coverage of the question. Directly after that, we'll go to Professor Christmals from the Center for Health Professions Education at the Northwest University. Not only is Professor Christmals involved in health policy analysis broadly, but he's got very specific exposure to the attempt by Ghana to implement universal health coverage. So we'll do those 2 presentations one after the other. And if you do have any questions, please put those into the chat. But after that, we will open up to the entire audience and to the panelists and engage in some debate. We plan to finish this webinar at 1:30, pretty much on time. So let me then go straight on to our first speaker, Professor Ronel Burger, and Ronel will share her slides and go straight into the presentation. Thanks, Ronel.
Fantastic. Thank you, Andy. Can you all hear me and see my slides?
We can perfectly. Thanks.
Okay, fantastic. Yes, this is a topic that I'm very passionate about. So thank you for the opportunity to talk about that today. I just want to see, I'm going to stop sharing because I have some issues with I'm just going to reshare. I couldn't move the slides. Okay. Okay. Yeah, it's fine now. Excellent. Yeah, I'm very grateful for the opportunity to share more about accountability, and specifically accountability and information systems and their role within the NHI. So just in terms of a perspective, I think it's useful to talk about the vision of the NHI as a framing. From the NHI preamble, we have these words that we are pursuing an equitable, effective and efficient utilization of resources in our health system. And this would be the way that I think we should sum up the pursuits of the NHI. We know that a big motivation for putting the NHI in place has been the very deep inequalities in our health system. For instance, I show here recent research, 2018 research that demonstrates that even 2 decades after the end of official end of apartheid, we still have very wide discrepancies in deaths between wealth quintiles. 26 deaths per 100 live births amongst children under 5 in the most affluent wealth quintile, while we have 60 deaths, more than twice as many amongst those in the bottom wealth quintile. And of course, while all types of inequality are an affront to social justice, I think health inequality is particularly problematic, partly because it is literally a life and death issue, and because it affects human dignity so clearly. In fact, Dr. Martin Luther King Jr. said, of all forms of inequality, injustice in healthcare is the most shocking and inhumane. So in terms of the pursuit of greater equity, there's both a social justice rationale, and related to that, ideas around the basic right to healthcare, but also a lot of empirical evidence showing that the poverty traps that operate via inequalities in health outcomes. And then there is also a growth and efficiency rationale through the human capital approach. Human potential and humans are incredibly important to societies, and not only inherently, which is the main argument, but also because they can help us grow and function better if we invest in them, as most functioning societies do. And that is the secondary reason for pursuing greater equity and improved health outcomes in South Africa, and part of the motivation behind the NHI vision. Why is accountability vital for achieving this vision? Firstly and foremostly, because it's a basic right. And specifically these declarations, Alma Ata and then the Astana declarations, speak about the fact that citizens need to have an active role in maintaining, promoting and restoring their own health, but also in the planning, organization, operation and control of the primary healthcare system. Additionally, we know that in terms of governance, health workers and policymakers are appointed essentially to serve citizens, and thus they need to be responsive and accountable to those citizens. That is the way a democratic state has been set up to work. And then I think there are also more pragmatic reasons that are, as an economist, I feel as important as an underpinning of, why we pursue accountability and why accountability and transparency should be non-negotiables if we really want to achieve the NHI's vision. And those are principles of good governance. Specifically, I think one is worried about good governance given the current state of parastatals, and also, of course, the fact that the NHI will pool resources even more than they are pooled currently. So we're talking about sort of a really large a source of power and a source of control over funding. And principles of good governance generally include accountability, needs responsiveness, because this enhances equity and social justice, and accountability is vital to ensure that the services provided honors the dignity of people and are people-centered. In terms of understanding accountability, I want to give a little bit of the theory, but not too much. This is the way that I usually in my lectures explain accountability to my students. So the idea is that you have this pyramid with the client or the citizen on top. I know that in economics we often call patients clients, but it might be more acceptable to say citizen, but that has its own issues and dilemmas. We can say individual. The citizen has a relationship with a policymaker through through elections, where they elect a specific government. The difficulty there, of course, with that accountability and feedback relationship is that this is quite a weak link, because elections are quite irregular, and because of all of the other issues around democracy and the limits of democracy, accountability through this political system. That all left aside for the to ensure that we have enough time. This power that's bestowed in the policymaker and responsibility that's bestowed in the policymaker and the government, they then use that to contract with a number of providers. And you can think of these providers either as frontline workers that are paid to provide a service to citizens, clients, individuals through a salary, or as contractors, such as specific agencies or even private sector providers. And of course, the contracting there is very important. We won't go into it. But the point is that the key point here is that the policymaker and the government cannot outsource their responsibility to deliver certain services, but they can outsource the actual service delivery. The difficulty now here is that because of this long arm of accountability that operates via elections, the political system, and then through contracting between the policymaker and the provider, this is called the long arm of accountability, and it's quite cumbersome to establish accountability and responsiveness through the long arm. And the other option, sort of a direct link between the provider and the client, is also often quite difficult, and that is why systems like voucher systems, etc., are often proposed to try and create some link where often there's no link of accountability. But that is also why information is so important, and I'll talk more about that for the rest of the presentation. Just to give some idea also about why accountability is specifically important in health services. I know intuitively we all understand that, but I think just to make it very clear with a tangible example, if you think of the principal as the person who buys and also observes the quality of a service, but also it can be a product, to show the difference between the real complexity of health services and then the relative simplicity of something that is easily observable and where feedback systems work very well, like a sandwich shop. I can talk through these arrows to just demonstrate that. In terms of delegating, I delegate my wish to have a sandwich to the agent, who is the provider. I then finance it by giving him the money. He then gives me a sandwich. Through eating it, I inform myself of the quality of the sandwich and then pay him. Yeah, I mean, the enforcement is very clear because I am the payer. The difficulty here is quite clear if you start to compare the very simplicity of eating a sandwich with something far, far more complicated, like the quality of health services. The wonderful thing about the simple example of eating a sandwich is it's very clear that if I have a bad sandwich, I will stop buying from the person who gave me a bad sandwich. Or even if I had to wait long for my sandwich, I will stop buying sandwiches from this person. This person is then very likely, this provider is very likely to not do good business, and they're more likely to face difficulty to survive and might be replaced by a competitor. Ideally, one would want to use information and use accountability in ways to restore the feedback system in health as well, and to ensure that individuals who are giving a good service and organizations that are delivering a good service would be rewarded, and those who are providing poor services are then supported or penalized to ensure that there's overall quality improvement and a high standard of responsiveness to communities are maintained. I just want to give two quick examples about sort of the difficulty of observing quality in health services. This is from a standardized patient study that we've done in 2016, where we've sent standardized patients to clinics to try and understand what's really going on in the interaction between between the patient and the health worker. For me, this is relevant because it takes a standardized patient to get this information. This is information that happens in the private context of the interaction between the provider and the patient, and even a health manager, even a facility manager might find it difficult to get this information without intervening in this very cumbersome way that we did by setting up a standardized patient case and training community members as standardized patients. And the idea is that they would present with a specific case, and they would say that they've tested before and had high hypertension, and we used individuals with slightly elevated hypertension. And the cases here only reflect those where the individual tested as hypertensive on that day. And what we find here is that the screening for hypertension is far from ideal. This reflects interactions, about 200 interactions, I remember, in East London and also in Cape Town area, roughly about 40 primary facilities that were visited by our hypertensive patients. And what you'll see here is that overall very poor performance, both in terms of providing lifestyle advice for controlling hypertension. These are now individuals who've tested as hypertensive at least twice. One was based on the initial information. They said that they tested hypertensive before, but the other one was in the clinic. We also find that the importance of regular high blood pressure testing was not stressed in more than half of the cases. Very often the risks of high blood pressure were not emphasized, and 28% of cases were a failed visit where the patient was not alerted to the fact that they might be hypertensive, and there was no follow-up visit scheduled, which is a substantial worry and concern in a country where cardiovascular disease is responsible for so many deaths each year. The importance of information in this context is further emphasized by additional work that we did, where we've asked facility managers in the Eastern Cape how often they think their nurses fail to give essential lifestyle advice, all these different metrics that I showed here: stress management, smoking, alcohol, exercise, weight control, diet. When somebody screens as hypertensive, they thought it happened in 83% of cases. That was the average across the 20 facility managers. In these same facilities, we did exit interviews, and also we had the standardized patients. And what we found is that in reality, all 6 different lifestyle advice dimensions were covered only in 10% of cases based on the exit interviews with real patients, and only in 14% based on the standardized patients. So this incredible divide between what facility managers think are happening inside the private interaction and what is actually happening, I think is an important illustration of how difficult it is to extract information on quality of care within the health system, how far the health system and health services are removed from the eating a sandwich example. And that is why I'm passionate about better information and better accountability and feedback systems in the healthcare system. The slides that I'm skipping over just says the same for TB. Andy and I did a chapter 2 years ago, and based on that, we identified some of the main shortfalls in the current system, shortfalls in accountability and also information systems. There's definitely an important and pertinent need for enhanced community ownership and provider accountability. We know that often the clinic committees are not functioning as they should. And the accountability channels are not always perceived to be effective. There are also issues that about sort of how much ownership and control local entities and local facilities have over service provision. And that brings us to 3 binding constraints for improved accountability in the current system. Firstly, there's limited devolution of decision-making and power in public health system. Secondly, there's a feeling of disempowerment and also low expectations of health providers. And then lastly, is the information access. We lack timely access to information on local facilities, providers, and also environmental health indicators. This is just a further illustration of this interaction between the citizens and the provider and the government. But I think what's important here is to also acknowledge the wider accountability frame that involves the judicial system, information per se, but then also the media and the NGOs, advocacy NGOs that can help to remedy failing accountability systems, and has been incredibly important in very crucial ways over the past decades. Understanding what type of information we need to boost accountability. Andy mentioned this, and I think it's important to be very clear and thoughtful about the information, the types of information that would really improve accountability and enhance accountability. There are a couple of things that are noted here. For provider quality and environmental health, it would be vital that indicators are widely viewed as credible, reliable, and accurate. It needs to be available at regular intervals and enable tracking over time. We need these indicators to be available in a timely way and at local level. We cannot wait 3 years for data. They need to be early indicators. It doesn't help that we only identify that there's a problem once people start dying. We need early indicators like child obesity. And then also it's vital that we have indicators that help us assess facility effectiveness, because the difficulty is that a lot of the outcomes that we do have available are co-created. They are they include a lot of social determinants. For instance, late access to care, TB cure rates. Often they're very much influenced by the social context of the community, and therefore they can't be used to hold local facilities accountable, because variation might reflect the community more than it reflects the providers, the nurses and the staff of the clinic, their motivation and their effort. Then lastly, in terms of patient voices, it's very important to have indicators that are easy to understand and that can be easy to interpret. And it needs to be clear why this indicator matters. Like a death rate is something that people care about intuitively. It's not difficult to explain why it's important. And I think that's the downside of a lot of indicators that are more more intricate. For instance, the index, it's not clear what's in there. It's not clear why individuals need to care about these things. So I think that's also important in terms of the selection of indicators we pursue and that we include in dashboards and promote. Then I'll end with just an overview of the shortcomings of the current information systems. Firstly, one of the biggest, and I would say maybe the biggest shortcoming is the fact that we have very little data available on outcomes. And this limits performance management and planning processes. We also need more information on control of chronic diseases. And relating to this, we need to be able to follow patients so that we can understand how well patients are managed. We need aggregated data on the use of medicine that can help us to assess drug adherence, drug safety, and compare outcomes for different drug treatments. We need longitudinal data like we have with the Western Cape Provincial Health Data Centre. And also we need more data to understand health inequalities. We need data on social and environmental factors that are crucial for health outcomes. And it's also vital to invest in intersectoral data systems that can help us understand the social determinants of South Africa's burden of disease. And as an example there, I cite the Blue Drop and the Green Drop reporting systems that provided very useful data on water and sewerage respectively. I think I'm going to end there to make sure that I don't take up too much of the seminar. I have some further slides, but I think I'll hand over to the second speaker at this point. Thank you.
Thank you very much, Ronelle. Thanks for that real scamper through the theory and with some really good examples. The questions are just popping into my mind. I'd love to get straight into them now, but let's go instead to Professor Christmal, who, as I said, not only engages in health policy research in this country, but has also had experience in other parts of the world. Christmal?
Thank you very much, Prof. I'm very grateful for the opportunity. I will want to put my presentation into these four compartments. So looking at a background and then also have some spotlight on what I really want to talk about. Then I want to lead us into a discussion on the paradox of the NHI accountability. Then put a call across for advocacy. By way of background, we know the history of the NHI, as Ronelle also made mention of in the beginning. So there's quite a lot of changes that took place at the beginning. You will see the face of Aaron. You know that we've seen this face many times on many platforms advocating and pushing for this bill when he was the Minister of Health. We also know there are many voices that had spoken clearly and also in many media platforms regarding the NHI and the need for clarity and in terms of whether it's going to work and who is going to pay for what. Those messages had come across. There were many stakeholder groupings that have either spoken for or against the bill at various stages and made inputs, as we have seen across many platforms. But the fact of all the issue is that we have crossed those phases now and have gone to a stage where the National Assembly had passed the bill. So whether we are either for or against or showing middle grounds in terms of whether the bill should be passed and implemented or not is no more the issue now. So I think we need to move on as to how we can make this work and in the best possible way that we can. We know we as an academics have also made quite a lot of inputs. We have advocated for the NHI and also stated reasons in terms of the inequity that existed in the current health financing system of South Africa that requires a shift in funding and also the management of funding in terms of healthcare. I will want to lay a disclaimer that I am quite for the National Health Insurance Scheme in South Africa. And so that might influence a few things that I would have said in this presentation. So I want to also focus on accountability. It seems today we are much more aligned to accountability, which I think is the bigger aspect of the NHI bill as we progress in the next phases that are going to unfold. So my presentation is going to draw on some experiences that I had in working on this paper from Ghana and also some other academic work done by my former mentor, Professor Rispool, and also a few other people in the space. So the big question that we need to ask ourselves is whether it's the public health or the private health sector that is more accountable to the South African. This question now creates a lot of diverse answers and also various arguments for and against the term accountability itself, and also to what extent have these sectors been accountable. From my perspective and from the work that was done by Prof. Rizal and co, I could say that both systems have not been very accountable to the South Africans. And so taking the argument forward, we need to know exactly which direction we need to go in terms of requesting for accountable governance and management of health funds in South Africa. Governance and also in terms of accountability in the literature have been shifted into three compartments. The previous speaker have really touched on this a lot. I think she's clearly an authority in the area. So there is the bigger portion in finance, performance, and also the third arm is political accountability. In terms of financial accountability, it's where the focus has been. Everyone wants to know what my money is being used for, whether it's efficient or not. So it looks at report on the allocation of efficiency. I think last year and the early part of this year I have led some systematic and scoping reviews for the World Health Organization, where we were looking at the efficiency of health systems in the Africa region, also look at how we can innovatively pool funds together to fund the healthcare, as much as we know that the current funding is not enough to take care of the countries in the Africa region. In the efficiency work, I think South Africa is not that bad. It's lying within the region of 70% efficient, which is on the average. We found that 77% efficiency exists within the sub-region, which means if you put in 100 rands into the health system, you could only account for 77 rands. So the rest will get missing at one point or the other in the health system. So financial accountability tries to deal with these issues about if we put in this amount, how much can we say have really gone into the provision of the health services that we need to provide for our people. Then the terms of performance, it had to do with what are the targets that we set and whether we have reached those targets. And there's quite a lot of work done in that area by Prof. Rispo. You will see that compared to other countries that spend similar amounts of money in terms of the GDP on health, SA is performing poorly in terms of its health outcomes. And even within the sub-region, where SA spends quite huge on health compared to other countries, but then we could see that those countries are performing better in terms of the health outcomes than SA. So we want to find out what is happening to the targets that are set and whether we are tracing and tracking the investments that have been made into these health services that we need to provide for our people. The third arm, as I mentioned earlier, deals with political accountability, and this focuses on institutions and procedures and mechanisms that are put in place to ensure that we maintain the public trust in the leadership. Also, we aggregate and represent citizens' interests, whether we are actually doing this for the citizens or it's for personal and parochial interest, and also how these institutions can respond to the critical needs of society and the concerns that all stakeholders have been raising within the implementation of health policies. Beyond the three aspects of accountability lies the bigger South African health system as we could see it now. I tried to model how the current nature of the social status in terms of what people can afford and what they are currently receiving, and why a lot of voices have not spoken and also defended or gone into argue for the public health system to be more funded and also be much more productive in terms of the services that are produced. We have in many times criticized the public health sector that is overcrowded, is poor services, is not functioning well and stuff like that. But what are the real contributory factors? If you divide South Africa according to the social status, you will see that about 49% of the population is chronically poor, which means this percentage from year after year are just poor. There is no amount of energy and investment that is going to lift this within a short period of time to cross that barrier. Then there is this 12% that are transient poor, which means they drop into the chronic poor, then they move a little bit above the range and come back. So moving from the chronically poor to a vulnerable middle class, this is that group of people. We also have 15% of the population that are vulnerable middle class, though they are kind of middle class, but then they have the tendency of also moving into being a transient poor if they are not easily sustained or if they are hit by a little bit of stress in the system. Then there is this stable middle class, which is comprising about 21%, and then the elite class, which is only 3%. Now, if you look at the current health provision, you will see that the chronically poor and the transient poor are stuck in the public health system, which we see is not really performing. There is nothing they can do. They are stuck there. They cannot defend themselves because they are highly vulnerable and they need people who can speak for them, but those voices are not available. Why? Because the voices that are actually up to the task, they have capacity in terms of knowledge, in terms of literacy level, they can read, they can evaluate stuff, they have access to the media and other forms of advocacy platforms, are in the stable middle class, who in most of the times when they get into the public health system and they feel like, no, we cannot cope with the poor level of care that is provided and the insufficient resources, they flight into the private healthcare system because they have some means of affording that maybe for a short period of time. Then in the private healthcare system, when they now realize that their funding is exhausted, they can easily move back into the public healthcare system. But there is this also the vulnerable middle class who are in there fighting, trying to raise their voices against the injustices and other things that are perpetrated in the public healthcare, but they don't have that strong voice compared to other people who are supposed to be advocating for quality care in the public health system. And here lies the bigger aspect of the GEMS medical aid, which government in itself is providing an escape route out of the public health system for people who are in the middle class and even above, who are supposed to watchdogs over the public health system, advocating for quality care and co. They are not there. Now, if you don't drink from a source, there is that human nature that you are not going to ensure that source is clean enough for others to drink because we are selfish in our nature. Now, if you go to public healthcare and you receive care from there, there is that high likelihood that you are going to fight for the quality in the public healthcare system. So I feel like the NHI is going to bring more voices into the public healthcare system in terms of advocating for the quality of care in that system, which is very critical for every system to work. In terms of the implementation, at this stage that we are, it's even much more critical that everyone partake intensely in the implementation process. We must critically engage government and its agencies in terms of how much they can invest in what and how funding is made and who is accountable, where is the money, and who is really using the money for what. These are critical things that we cannot run away from now. And continuous advocacy in writing and also presentations across board are going to be very important when you deal with these things. Because in other experiences, for example, in Ghana, most of the people who are currently receiving the care are the poor and the middle class. The upper class still have their private medical insurance, which works in the private healthcare centers and not in the public health system. And so they really don't care about the national health insurance. And so most of the weaknesses that the system have is because the voices that are supposed to speak for it are not speaking. The bigger aspect of it is that immediately we go into implementation, people who hitherto have not been receiving healthcare or some conditions that they just go and treat with maybe a GP or co, they will run into every provider for the national health insurance to go and receive care. In Ghana, for example, utilization had more than doubled when the implementation started. Now, that will also demand more health workers. So what Ghana did was to introduce some more programs and nursing colleges and co to raise more health workers to provide care for the people. But there is that transient nature of health workers because you cannot produce a medical doctor in 3 months. So in terms of implementation, we need to put our voice. How much enrollment are we doing? Are we increasing enrollment as against when the implementation is going to take place? If we need a nurse or we need to increase the number of nurses by maybe 2,000, we cannot do it in 1 month or 1 year. So at what point should we take these steps before we say we are rolling out? We can see this in the National Student Financial Aid Scheme, which has been just implementing a lot of changes, and the chaos is creating currently in the higher education sector. We at the Northwest University have to ask our students to go online for some time because their funding has not been released to them. Some of them have been poorly evaluated, and so they were funded and they were defunded at the middle of the year. Are we going to go into that chaos? Now, we cannot compare healthcare to education in terms of the critical nature of the services that are provided. Do we want to stay on the fence and wait until we go into these critical issues before we start talking and start engaging? So I will enforce and treat a lot of our colleagues and all of us involved that please engage, put your voices on the table, write as much as you can, because I see that the more we write, the more politicians read. We can say that, oh, politicians don't read papers, but I can tell you they read because I've received quite a lot of calls from political classes asking me about one of the papers we did on the NHI, what are the things involved? So they read and they use it at different levels of engagement and also for and against each other in terms of their political debate. So let's keep writing, let's keep talking about it, let's keep investing in all the medium that we can in terms of talking about every form of weaknesses that we could find in the NHI. I believe that the government is listening. I believe most of the voices that were heard resulted in some changes in the final bill that was passed. And so going forward, let us continue. I want to also thank the Health Justice Initiative for these initiatives that they are bringing on board. It's really important in this day and age that they create this platform for engagement. Don't forget to click and also donate for the organization to keep on its work. It's really important. Thank you very much. And if you have any questions.
Thank you very much, Chris Mal. That was a wonderful walkthrough and some really good insights from your experiences in Ghana. I don't see any questions in the chat at the moment. Please feel free to raise your hands if you'd like to speak. I'll try to identify who it is that's speaking. But before we get into it, perhaps I could ask either of the speakers or the HJI leadership to reflect for a moment on the design of the NHI bill. We have a very strongly centralized structure, a single payer and a single fund that is created at the national level of government. In addition, the district health management offices that are created by the bill are also going to be referred to as national government entities. Then we have the contracting units for primary care services. And there's confusion as to whether those are actually contracting units or they're the ones who get the contract to provide the services. So they're the mix of public and private providers at the level of service delivery. So In your initial reading of the bill, do you see this as very much a high-level national centralized accountability mechanism and hence through the national parliament? Or do you see strong structures created for local level accountability in the ways that we expected clinic committees and hospital committees to work? I don't know if either Ronel or Chrismal would like to take that, and then perhaps we can open it up to Fatima and Marlies.
Chrismal, do you want to answer first, or how do you prefer to do it?
I
Ronel,
think you can.
you can get going. You're the one who unmuted first.
Okay. I think there's great concern about what is currently outlined in terms of governance, both at a macro level and at a micro level, micro local level. And I think although the decentralization of buying is in principle something which I think makes sense, and there's been some evidence that it might work, I'm still worried that in South Africa, it might also further enhance inequalities. So I think it's the one cannot substitute for the other. We definitely need both accountability mechanisms and governance mechanisms at a macro and a micro level. And I think it's in my opinion, one of the biggest emissions and causes for concern is that I don't see that engine for quality improvement and self-scrutiny and problem identification in the design of the bill, unfortunately.
Thanks, Chrismal.
Thank you, Prof. I think that if you compare what the system is trying to provide to maybe what happened in China and Ghana, they've tried to align it with experiences that exist. So, for example, in Ghana, there are also district offices. There is this contracting unit, which are actually service providers who make the claims, and these claims go through the district at some point in time. Currently, they have shifted to online claim and also verification. So if I go to the hospital, for example, I receive treatment for ABC, the hospital then clicks in their system and claim. Then I, as a patient, will approve on my mobile phone. Then the National Health Insurance Authority then receives that claim as duly authenticated for service provision, but also that have weaknesses in terms of people who cannot read and write. So they try to align this, but most of these government-instituted policies are in there to protect government policies, and also they are, in one way or the other, a vote buying opportunities. So they will not release the power easily to other stakeholders in terms of who can be there as a watchdog on them, because at one point or the other, they may want to maybe move funds, which Ghana also does at some point. They move funds from the National Health Insurance Authority into other sectors that need it now, thinking of bringing it back in the future, which doesn't happen. So the public must do its role. You as academics and also people who are well-versed in the knowledge of these things must speak out, must write, because that is where we can keep government on its toes. Thank you.
Thanks, Chrismal. So I think the point that is coming across is that there's a lot of emphasis on public financial management of a 3A entity, the Public Finance Management Act, but that is very, very different from accountability for performance to patients and the general public. And I wondered if there's anyone from the Western Cape who can comment on the fact that the provincial legislation in the Western Cape for the district health system has focused on governance structures, on facility clinics. Is there evidence of that working in the Western Cape, or is that as ineffective as it is in the rest of the country. Anyone like to take that up from the Western Cape perspective? I'm looking at people like Lauren, Marlies, Fatima, who are Western Cape based. Alistine, perhaps. Out of my depth on that one, Lauren. So Fatima, do you want to weigh in a little bit on the structural problem? You know, what is the governance structure that is created, and is a board accounting to Parliament the same as a board accounting to the people?
So, you know, I can speak on this for about 10 hours, so I'm going to try and do this in 5 minutes. So I think first, just thanks to Andy for moderating and really fascinating input from Ronel and the Prof, both around social injustice and inequality and sort of the experience of Ghana. And as I was listening to the presentations, I just realized that this opportunity that's been given to us to make submissions by the 1st of September is something that we all really have to take on board. Because barring litigation, this is probably the last opportunity we have to try and convince our lawmakers that the design is actually really weak and is quite imperfect. But where we're coming from is very different to where the opposition political parties, and I think Prof mentioned about sort of the disputed, you know, interpretations of the NHI bill amongst the different political parties. Where we're coming from is that we can't really see the accountability in decision making. So if you design a bill that says decisions are going to be taken around which medicines you will use, which medicines you won't use, which procurement will happen and when it will happen and at what price. And our focus as AGI really has been around this potential so-called merging of two very different, in fact, potentially three very different medicine systems. And again, there we've argued publicly that the design is so problematic that you could create a medicine access crisis or a medicine access cliff in South Africa. So the accountability in decision-making seems to be the minister, the DG, the board, the chairperson of different advisory committees. There's several that's been set up. And then also the different, I think we counted the last time, Andy, in the infographic we did on the NHI, 7 different technical units within the Department of Health, who our reading of it is that they're being taken from the National Department of Health, the name change will happen and then transferred into the NHI fund. Within those units, there's a equivalent of a clinical treatment guidelines unit, so somebody who will recommend that this is what's going to happen in the country on TB or HIV or COVID or cancer, for example, and then also units that will actually be doing the procurement. So for us, what's really missing, you know, even if this was the cleanest government in the world, even if this was the government with the least amount of corruption allegations or corruption in health procurement, you still need accountability. And accountability can only come, I think Ronel mentioned SOEs and the experience there. There isn't even language in the bill that the conflicts of interest will have a public register or mandatory disclosure, right? There isn't proactive default provisions for the minutes of meetings to be made immediately available within 24 hours. So somebody's making decisions around what cancer treatment you're going to get or not get because of whatever reasons. Could be affordability, it could be an issue with the drug company, it could be a patenting issue, but you won't really know the basis for that. And that is what some of us were fighting for during COVID. So I'm really concerned. And again, even if this was a government that was really functional, was really well run, we didn't have all these issues of corruption, we would be making the same argument, because you can't have trust in medicine selection decisions and trust in a public health system if there is no accountability for the decision. So I'll give you 2 really worrying examples, because without that language in the bill around proactive disclosure, around automatic disclosure, around automatic sharing of information, is we will all be filing access to information requests over and over and over again to try and find out the decision making behind a choice by the National Department of Health unit or advisory committee or the minister or the DG. Sometimes it's a bit difficult to figure out who exactly can make the decision about why you as a poor patient cannot access an essential life-saving treatment or treatment regimen, right? And when you eventually get the department to answer, the trend of the department, and we've seen this in COVID, this was a cabinet decision. How was cabinet involved in making decisions during COVID around clinical decisions, around the pausing of the AstraZeneca vaccine? And as such, the argument was that a cabinet decision is part of a cabinet minute and that's confidential. We have no duty to disclose this information. Even on the MAC advisories, we have no duty to disclose this within a certain time period. The minister will decide which MAC advisory should be made public and when and you know, with how long. So I think what, you know, final point on this, Andy, is that the Department of Health has gone on a PR offensive. It's giving wonderful interviews. It's saying the most beautiful things, but that doesn't translate into what's in the bill and its design, and its imperfect design, or how it's going to be implemented. So you can say you're committed to transparency and accountability, but we can't find the provisions. There's one new clause, one that was added from version A to version B. And so we're all now dealing with version B of the bill, right? That's the bill that Parliament and NCOP will decide on, which basically said that in two respects, the minister wouldn't have the exclusive power to make some decisions. You'd have to actually go to the full cabinet and the NHI board, and that's like appointment of the CEO, removal of the CEO. So yeah, unfortunately, I think I'm just going to give everybody a big downer. I don't think it's promising. I think the design is really problematic. And I think people and opposition parties have been focused about their middle class access and their middle class problems. And I'm not saying that that's not legitimate, but I think there's a bigger crisis coming, and that's going to be about access to health services for poor people. And how do you hold those in authority who are going to be making life-changing decisions or life-altering decisions for the majority of people? And the way in which the bill is structured and designed is that all of those decisions and power is actually going to reside actually within the Department of Health in these different units. So, you know, read our paper, read our op-ed on this. You know, I'm not articulating it very well in the short sort of input, but yeah, there are major concerns and issues around who's actually going to be held responsible and accountable for the decisions that they're going to be taken. And you can extend our critique on the medicine access decision-making issues to any other aspect of the bill. I think it's a similar arguments that you can make there. And then truly last point is that there's no way the state can do this on its own. So the concern for us, and this is where we come to the role of the private sector, is accountability is not going to be just about the Department of Health and national government. If you're going to have to rely more on private providers to provide the services to be compliant with NHI, and if they agree to be accredited providers under the NHI, how do we hold all those players accountable? It's been very difficult for us to hold a lot of private health providers accountable, including private pharmaceutical companies. And then the last part of that accountability is that the provinces may well all want to do different things. We're already seeing the Western Cape talk a very different language. Things play out very differently here. And that could create some unevenness and uncertainties around who's making decisions in which part of the country and where. And the whole point of universal health coverage and NHI in South Africa is, irrespective of the province, you're all supposed to access the same quality of healthcare, right? But we're really worried that the road we're going down is, you may even, you know, have 9 different versions of NHI. So let me stop there. Thanks.
Thanks, Fatima. Let me focus this, and we've paid a lot of attention to medicines. So at the level of the benefits package, there's going to be very important decisions. Accountability for that could come through transparency, could come through sharing of the reasoning behind something being included or not included. The procurement or the reimbursement for medicines will involve the setting or the agreement or the negotiation of a price. What is paid is going to be really important to be transparent, reported, so that people can be held accountable for how that money is spent. But then you have to say, who gets those medicines? Is there equitable access to those medicines? And are the outcomes that you hope to achieve from those medicines actually being achieved? So I wanted to just quickly focus people's thoughts on that idea of effective coverage indicators. And Ronelle gave a very good example where, for example, in HIV, we've said that the most important indicator is the last of the 95s. What proportion of those who are on antiretroviral therapy have a suppressed viral load? But that is a mixture of what the health system does and what the patients do. What are the better indicators of the health system's provision? A very important element for many people is availability of medicine. Are the medicines in stock when they go to the clinics? And do they get the medicine that they feel they should be getting? And for example, the medicine that is in the standard treatment guideline for them that fits within the benefit package. And I see a number of people on this call today who might have insights into what we currently know or don't know about medicines access. So I want to, without putting you on the spot, remember this is a closed meeting. It's here for people to share, so don't feel that you have to speak on behalf of a particular organization or on behalf of government. But I wondered whether either Rob or Sue are wanting to share something about our ability to really know where the medicines are being accessed at point of care and some of the limitations of our current medicines availability data in the public sector and in the private sector. And then we can perhaps come to Bada and say, from an industry perspective, how do you see those data and how do they match up with what your member companies buy from the data providers to work on their marketing plans, for example? So the IQVIA type data. Rob or Sue, are you happy to make some input here?
Hi, sure. Yeah. With regards to visibility of medicine data, so there's a number of systems that have been deployed in the public sector to monitor medicine availability. Early days of this was quite rough, where it was pretty much binary, where you said either I have or I haven't got the medicine. And the challenge with that is, if I've got one on the shelf, it shows that I've got stock, but it does not necessarily mean that I have sufficient to meet the demand of the patients that I'm expected to serve. So there has been quite a bit of work to actually transition from that type of medicine availability to start looking at an idea to say, do we have sufficient to meet the demand? So a lot of work is going into minimum and maximum levels based on demand at facility level, and also looking at the indicators with regards to what type of patients are actually being served, together with the package of services there. So I think there's been definite improvement in that. It's never foolproof because we rely heavily on people to input the data. And often with these type of systems, you find that increased visibility leads to certain challenges. And I'll explain just one of those. Is one clinic that reports consistently that they've got sufficient stock. The one down the road doesn't have sufficient. They know that if they report correctly and that they show that they have sufficient stock, there's a chance that somebody's going to come and collect it from them because they've now provided sufficient inputs to say, I've got enough stock to service both the needs of my facility and potentially the one down the road. So it's trying to make sure that everybody gets what they need, everybody orders what they need when they're supposed to avoid those type of things, and so for us to be able to trust the data that we're seeing. The one interesting question that you did raise around private sector was during COVID, we had a very similar situation where we wanted to understand before we knew the full implications of what COVID's meant for us. We wanted to understand across the sector, both public and private, is who's got what where. In case public sector ran out of stock, in case private sector ran out of stock, we knew what our stockholding was in the country. The problem that we had is that there was no single data set that we could use easily to analyze that data. Our request to private sector resulted in multiple proprietary identifiers, multiple naming conventions for the same product, which really didn't assist us in that. So I think there is a lot of work to be done in standardizing how we talk about data to actually assist us in improving that visibility. But one of the things I do want to say about the difference between public and private sector is it comes down to a service delivery model, in that private sector, and most of us probably access our medicines through the private sector, is you can walk into a pharmacy and with your prescription and they say, listen, I don't have it now, but I'll either deliver it tomorrow or I'll send it to you tomorrow. And we will accept that. If you've got chronic medicines, they usually inform you well in advance. You acknowledge, you can say you can pre-pack it for me. They can order it. They get next day to 24-hour to 48-hour delivery turnarounds from the wholesalers that they access their medicine. However, in the public sector, we expect all those people to keep all the medicines all the time in case somebody presents with a prescription on that day that they may not have anticipated. And if we are unable to support that or supply that medicine on that day, it gets classified as stock out of a stock shortage, where we don't have the same classification in the private sector. So we do need to understand the differences between the two models, but then we need to start addressing that ability of being able to get medicines to public sector in a far more efficient and faster fashion than what we're currently doing, where we have some public sector facilities that only get serviced on a monthly basis at the moment. We need to start looking for efficiencies in our supply chain to support that. Thanks, Andy.
Thanks very much, Rob. That's really great. Baarda, from the pharmaceutical industry perspective, what are the data sources that you think we should be using that we aren't using, and how do those compare to the data that you're able to get, but at cost?
Thanks, Andy. What a tricky question. Now, being one who operates at the level of the association, I am not involved in the cold phase of what happens with data and so on. But I would say that one of the things that would have been unraveled had the Department of Health decided to consider implementation of the health market inquiry recommendations would have been a whole lot of issues becoming a lot more transparent within the private sector. And in fact, regulation, we're talking about regulation and accountability, and the fact that a lot of people don't see much accountability within the private sector has to do with the fact that much as some of us in the private sector might complain that the private sector is overregulated, I think people tend to conflate regulation with obstacles that actually prevent investment in the private sector. That kind of overregulation is definitely true. But in terms of outcomes of treatments and so on, I think there was a real opportunity for the establishment of some kind of institutions that the HMI inquiry had proposed, such as one that would help patients appreciate whether the treatment that they received at high cost to themselves at times was actually worth it. The fact that we still don't have health technology assessments, especially an opportunity to have HTAs done by an agency that is not linked to the government, that is therefore not going only to look at cost, but also look at the investment opportunity in certain treatments. I know I'm not talking about data here, but just talking about accountability, I think those are some of the things that could have been looked at.
Thanks, Bader. Let me not dominate completely. So if there's anyone who'd like to raise anything either to the two speakers or anyone else on the call, please put your hands up. If I don't see any, I'm going to take us down a slightly different angle. I'm not seeing
can I
any
raise my
hands.
hand while I'm trying to look?
Yes, certainly, Bader.
Okay. As I was listening to the presentations on accountability, I find that there was very little said on performance accountability in the public sector. And it's something that's experienced not only by those who want to use the public sector services as ordinary citizens. It is felt also by the private sector providers who need to access certain services in the public sector. I had the opportunity a few days ago to have the chairperson of the Public Service Commission address my CEOs on how one could hold government departments accountable. You have departments that simply do not do what is expected of them, that decide to come up with their own interpretation of the Health Act or any other act or any Public Service Administration Act. And one wonders if it takes an institution, a Section 196, or is it 195, institutions such as the Public Service Commission to have to get people to do what they have to in terms of a constitution. How do we foresee or envisage having such accountability of performance under NHI? Because I haven't seen any structure that purports to take care of that under NHI. Should we not be talking more about performance management, performance accountability going forward? That's my question mainly to Prof. Burger.
Thanks, Bader. So before I hand that over to Ronel, perhaps just to comment on the role of the Office of Health Standards Compliance. That name is perhaps a little bit unfortunate because it sounds very much like a dichotomous thing. You either comply or you don't comply. The training that's been received by the OHSC staff has come from the United Kingdom's Care Quality Commission. And that sends a different message. It is about the quality of care and how that approaches perfection. You know, it's a bit like the Panasonic quest for zero defect. So I think we've got some of the building blocks in there, but at the moment, the OHSC is unable to assess all of the places all of the time, and their instruments are not effective enough to really tell us about care quality. That was illustrated very nicely. Ronel mentioned the Blue Drop and Green Drop reports that the Department of Water Affairs has reinstated, and the 2022 reports are out. But in terms of the wastewater treatment, there's no green drop assessment of the Thekwini Metro. It's so bad that they didn't even report on it. So I think it illustrates as well some of the problems that we have. And I want perhaps to come back to Ronel on the issue of disaggregation. How far down do we really need accountability to work, and to whom? Is it individuals who want to know, is my clinic up to scratch? Or is it communities? Is it civil society? Is it local government officials that might be held accountable by their voters for the way in which local services are delivered? Ronel?
Andy, we're missing at the moment so many of those building blocks. It's really quite difficult to imagine, how a system might function. I mean, one of the options would be that the accountability is within patient groups. Another one would be that it might be district level. I think the healthiest would be a pluralist approach where one has overlapping accountability networks and try and harness whatever is available to create positive feedback loops where there can be conversations about how do we improve this, how, and complaints can be fielded and listened to. And I think on all fronts, we have a long journey ahead of us, activating patients, mobilizing patients, ensuring that we have the right information available at the right level and in a timely way. And that I think the people who are using information for accountability really understand where this information comes from and also understand the limitations of the information that they're using. But at the same time, I also think there's massive potential to use information. And I think I agree with you about the NHI and the Office for Health Standard Compliance. In principle, they are there is alignment there, but I think there are also worries about their capacity because at the moment, I think the time frame was 4 or 5 years to just go through the entire system of public clinics, and that's clearly not adequate. That clearly won't do the job as sort of the sole source of accountability. There were also sort of, in terms of payment mechanisms, some monitoring, but I think what I'm worried about is that a lot of it seems to be a focus on outputs, not really a focus on quality. And I think that's a real concern. Also, specifically given sort of the huge amount of funding and the lack of competition that I see in the current design. So yeah, perhaps more questions than answers at the moment, but I think questions are a good place to start.
Thanks, Ronel. Chrismal, in Ghana, where they indicated that the CUPS design has been used as well, do the district officers hold the CUPS accountable, and do the public have access to that data? Can they understand which CUPS are doing better and which CUPS are doing worse?
Thank you, Prof. So mostly the accountability in the Ghanaian system is from the National Health Insurance Authority, which is a body, as we are also seeing, that will be established for South Africa. So that body is responsible for ensuring that the providers provide what they have claimed for and what the accreditation gives them limit to. But you will see that sometimes there were some cases of them shutting down some providers because they had even falsely claimed for services that they have not provided. So it's not really going to be only on the side of government being accountable, but even the providers, because some of them will try to beat the system and overclaim. So how do those systems check itself? So that's why you see that the patient, him or herself, must also be part of that system, because the numbers, so in Ghana, they give every patient or user a specific number through which you can claim. So if those numbers are provided to the district service for services that were, the district National Health Insurance Office for services that were provided, how the cross-checking is done is problematic, because at many times even the receiver is not aware of numbers being provided, because hospitals have it from previous registration and stuff like that. So that is why trying to go digital in terms of cross-verification, as the system allows now, is important. But government is going to always have its way, one way or the other, because of they being the sole purchaser and also appointing. I'm very sure we need to really check how these boards and the district offices are going to be composed, and who is going to be, whether civil society and other stakeholders will be on these boards and offices, because that is where the real closure in terms of how much information is made available to stakeholders will be done. And so there must be quite a lot of fight to ensure that government doesn't put politicians, and we can really tell what is happening in the state-owned institutions currently, where only government puts people there, and the quality of people and administrators that are appointed there. So the big issues will start from there, because when we get it wrong, it's going to trickle down for a long time. And so we need to keep our eyes open as the processes unfold.
Thanks, Chrismal. Thanks very much. So I want to end with a positive note. The private sector in South Africa has so much more data because it's built on a system of claiming. Financial decisions drive the availability of data. So that means there is a potential in a system based on reimbursement of far better data in the NHI than we've got at the moment. But let's also look at accountability. The private sector has not allowed for effective accountability. For example, by members and beneficiaries of medical schemes holding their scheme administrators accountable for the quality of care that they get. They've also not been able to hold their private providers accountable. And we have lots of examples of poor quality care being delivered in our high-priced private sector in South Africa. So the problems lie on both sides of the fence. The solutions now have to be common to both sides of that fence, but they have to be proactively designed in, and some of the principles should be entrenched in the law so that we can hold people accountable to those. So I want to end by giving Fatima one last chance and to ask her particularly around the constitutional obligation to transparency in terms of government procurement, and what lessons we might have learned already about the limits of that constitutional obligation, and how difficult it is to enforce what should be a right that the people have. Thanks, Fatima.
Thanks, Andy. So I think that the concern is that even under NHI, in the way in which the bill is drafted and in media interviews, there's this, we're going to be transparent, we're going to be accountable, is, like I said earlier, practically it doesn't happen. So it's a fight for civil society to continuously try and get procurement information. There are many companies who are globally, it's a pattern not just happening in South Africa, demanding secrecy and non-disclosure agreement. And so unless we fight for language in the bill at the outset to ensure that the default is proactive disclosure, we are concerned that we're going to have to continuously fight for this, and that companies are bullying countries like South Africa into NDAs because they don't want to be transparent around not just pricing or the pricing formulas, but on a whole range of other provisions, including non-delivery, late delivery, breach of contract, etc. So we've recently been in court, and unfortunately our government is defending the secrecy and saying that they sign confidentiality clauses and they can't disclose the vaccine contracts. And so the default situation you could create with an attitude like that is you could use access to information laws, which is something we really shouldn't be having to do in a democracy, to try and get access to a contract where public funds are used. And under NHI, all procurement will be decided by this procurement unit, which will be based in the NBOH, based on the advice of what's called a Medical Benefits Advisory Committee. So they'll decide all the packages, all the pricing, all the medicine. And unfortunately, they've argued that there isn't a right to automatic disclosure. And so if you have to keep on filing access to information requests and the department can just, basically reject it out of hand, it means all of us will keep on having to go to court to ask for the disclosure of a contract. In this case, it's taken us 2 years. None of us have the time and the energy to be seeking access to every single contract. So we need a systemic solution that the default has to be disclosure and proactive disclosure, because it is basically using significant amounts of public resources. This is not procurement that is being funded by the minister himself personally. It's actually funded by all of us in South Africa. And so, that's one of the reasons why we're demanding accountability in procurement as well. Thanks, Andy.
Thanks, Fatima, and thank you everyone for your engagement and your presence here today. It's really appreciated. To those who were the victims of my pointed questions, the previous acting DG used to say that my questions were career limiting. I hope I haven't done that to you today. Thank you very much for your involvement in this webinar series. What will come out of here will be not only a report, but also ongoing advocacy and engagement. So the point that has to be made is we are not yet at an NHI Act, which is heading to the president for assent. There is still a very important NCOP step. There is now a call for input to the NCOP, and as we've seen in the Western Cape, the beginnings of engagement and a commitment to take that engagement to every single district in that province. Will other provinces be the same? That's still to be seen, but let's make sure that the NCOP process is not merely a rubber stamping of what has already been decided in the National Assembly. Thanks, everyone, and thank you especially again to HJI for hosting this series of webinars. I hope that we have contributed to your understanding and also contributed to the quality of the advocacy going forward. Thanks, everyone. Thanks.
Thank you, Andy. Thanks, everyone.
Thank you.
Bye.
Thank you. Bye.
Thanks.